Well, good morning, good afternoon, good evening, wherever your time zone is located. Welcome to this webinar. Thank you so much for joining us today. You're from more than 60 countries from all around the world, so it's great. My name is Cécile Fernandez, and I'm with Subtítulos, and I'll be your host for this webinar on special needs patients today. And I am glad to welcome our panelists, our KOL, actually my co-hosts today, no other than the internationally renowned Professor Stanley Malamed. Welcome. I don't even know if I need to introduce you because actually the enthusiasm around this session speaks by itself. It speaks volumes. I've received tons of emails. We have a lot of registrants today, and it's just astounding that you guys are all here from all around the world, and I think we may be breaking some kind of record. So welcome. Just a quick bio, and correct me if I'm wrong, Professor Malamed. You're a dentist, anesthesiologist, an emeritus professor of dentistry. You were a teacher at the University of Southern California School of Dentistry from 1973 for 40 years. You're a diplomate at the American Dental Board of Anesthesiology. You're the author of more than 170 scientific publications, and of course the author of widely used handbooks that you will actually present in a couple of minutes. Maybe you just want to say a quick welcome, a quick hi. No?
You said it all. No, it's a pleasure to be here. You know, we've been doing Zoom now for the last couple of years, and I was just telling you before the broadcast started, it would be so nice to be able to get out and visit your countries and do this live and in person. You can do a lot more. You can, if anybody's ever heard me speak before, I like to tell stories and tell jokes, which don't really do well on Zoom or webinar broadcasts. So I hope you enjoy the program. I hope you get something from the program. And at the end of the program, of course, we'll have some time for questions and answers. So let's give it back to Ms. Fernandez, and let's get going. Okay. Enjoy the show.
Yeah, all right. So Professor Malamed will talk today about a few of his favorite topics. Obviously, dental local anesthesia and sedation techniques for some special needs patients groups. So namely, actually, we are going to cover today pregnant and nursing women, geriatrics, and pediatrics. So obviously, if you are unsure on how to treat these patients, or you simply would like a refresher, you're in the right place. But first, as you've been quite enthusiastic about this session, as I said earlier, let's start by asking you, the audience, some questions. I will launch 3 polls before the actual program, and one after the other. I want to ask you simple questions, and so please vote so that we can get to know you better. I will launch the first poll, and okay, I just launched it, and if you can see it, I'm distributing the poll right now. So I'm asking you basically, how often do you treat special needs patients in those 4 groups I just said in your practice? So like 0 to quarter of the time, a quarter to half of your time, and more than 50% of your time, or either this or you are specialized in those special needs patients. I'll give you, it's been 40 seconds. I'll give you 20 more seconds to vote. We have a clear winner, so I think that you're in the right place today, definitely. I'll share the results in a minute. Don't hesitate to vote, just to get to know the audience better, and so that Professor Malamed knows who we'll be talking to. It's been a minute. I'll close the first poll and share the results. So, Professor Malamed, I don't know if you can see the results, but most of the people have. Yeah, great. most of the people have voted that they treat special needs patients, or those groups at least, less than a quarter of their time. So I think that they're in the right place today, right?
Right. Good.
You will be learning a few things on those patients today. So thank you for completing this first poll. I will share another question about the sedation techniques you use on those special needs patients. So if you don't treat them currently, you can not answer. So do you use sedation techniques on your special needs patients, on the one that you are treating today? Thank you for your vote. I'll just leave a couple more seconds. I can see the numbers are raising. Don't hesitate to vote. All right, so it's not rising anymore. So I think most of you have voted already. I'll just share the results. Professor Malamed, can you see the results on your screen?
Yes, I can.
Care to comment?
No, I think 38% is a pretty good number for these doctors who are doing some kind of sedation in this patient group. I find that pretty impressive.
Great. The other 62% might learn something today.
Yes.
There's a last one, so please get your vote on. What is your drug of choice to use on those special needs patients, which I said earlier? So pregnant and nursing women, sorry, geriatrics and pediatrics. Still collecting answers. Okay, good. A lot of you are voting. Thank you for taking part in these small polls. It's always very nice to get to know our audience better. So you're coming from all over the world and still coming, I can see. I'm closing it in 3 seconds and sharing my screen. Closing it now. Professor Malamed, do you see the answers?
Yep. It's there. Got it.
All right. Care to comment again?
The only comment is that if you look at the lidocaine, articaine, bupivacaine, those in that sequence are the most used local anesthetics in dentistry worldwide. Lidocaine is the #1, articaine is #2, and bupivacaine is #3. So the audience is fitting into the exactly what we would expect. No
Great.
surprises here.
No surprises there. Great.
No.
Perfect audience then. Okay. I'm back here on air with you. Oops, sorry. Just paused still showing my screen. Sorry, so thank you very much for everyone to taking part in this little icebreaker. As I said, we love to know more about our audience. So just a quick thing, just a couple of basic rules on how this session will go. As a reminder, you are all muted. We have actually recorded the presentation for Professor Malamed a little while ago, so it could be subtitled in Spanish. So it's coming, and we are going to have subtitles. I will play the record just after these basic rules. During the the lecture, you will be able to ask questions through the chat box. You have a question in your control panel. However, I'd advise you don't rush in asking the questions because maybe the answer is coming right after in the program. It may be answered at that moment. And after the recording session, we'll have Q&A, and I will ask some of your questions to Professor Malamed here, who will kindly answer. So basically, see you in 45 minutes. Just allow me to do some technical stuff to launch the recordings, the recorded session, and we'll see you back in 45 minutes. Thank you.
Good day. I am Dr. Stanley Malamed. I'm a dentist anesthesiologist here in Los Angeles, California, where I taught at the University of Southern California School of Dentistry basically for 40 years, from 1973 until 2013. As a disclosure, I am a consultant to Septodont, the sponsor of this program. My email address is here, malamed@usc.edu. In case anybody has any questions for me, we'll have a Q&A session at the end of the program, but later on, if anybody would like to contact me concerning local anesthesia, sedation, medical emergencies or such, feel free to email me. I'll show you this slide again at the end of the program. These are my 3 textbooks. I have a book on sedation, a book on medical emergencies, and a textbook on local anesthesia. Today, we'll be discussing the 2 books, the sedation book and the book on local anesthesia. And our topic for today is pain management for special needs patients. So let's start out with basically defining, for our purposes today, who are our special needs patients. And what we'll be discussing today are 4 categories. We'll talk about the pregnant patient, the patient, the mother who is nursing her child, geriatric patients, and pediatric patients. And really, why are these patients considered to be special or special needs patients? And the answer is that pregnancy and nursing, the use of medications, in fact, what we'll be doing, we'll be discussing the use of local anesthetics and central nervous system depressants, which are sedatives, in these categories. So there are, as you'll see, there are concerns in giving certain medications to pregnant patients, to mothers who are nursing, in geriatric patients and in pediatric patients, as the way medications work in older patients and younger patients can be different than it is in patients who, let's talk about it, in the middle of that age curve, if you will, anywhere from age 6 up to about age 70 or such. We are discussing local anesthetics, and I want you to be aware of the fact that depending upon where you are, the availability of these 5 local anesthetics, and these are the 5 local anesthetics that are used in the dental profession, the availability may vary from country to country. Similarly, the availability of sedation techniques will vary from country to country. The techniques that are readily available, again, not everywhere, are oral sedation, inhalation sedation, which is also known as relative analgesia or RA, and parenteral sedation, which is intravenous, intramuscular, or intranasal sedation. Keeping in mind that where you're located, some of these techniques and some of these local anesthetics may or may not be available. So let's start out with our discussion of the pregnant patient and nursing. And one of the problems we're going to be facing throughout this entire program, especially with these first 2 categories, is the lack of research. And quite honestly, it is very, very difficult, if not impossible, to do ethical clinical research on patients who are pregnant or nursing. So as you'll see as we go along here in just a moment, the information about safety of local anesthetics and CNS depressants in the pregnant and nursing patient is sparse. So we start out with our discussion of pregnancy and what are our major concerns during dental treatment of the pregnant patient. And when it comes to the medications that we're using, again, in dentistry, we're using primarily local anesthetics. Some of you are using sedatives, antibiotics. Is number one, will there be any negative effects on the course of that patient's pregnancy? And we're looking here about the potential for spontaneous abortion. Will the medication that we're giving to the mother potentially harm the developing fetus? And we talk here about fetal malformation. Basic rules, and these rules are not new. I graduated dental school in the previous century, and they still hold true. We teach our students that during the first trimester of pregnancy, elective care should be postponed. Now, it's not because the dental work we're doing is going to lead to an increase in problems during the pregnancy, but that is the period of time when most problems occur. So let's get her through the first trimester. When we get to the second and early in the third trimesters, if necessary, dental care can be done. Late in the third trimester, if you look at the picture on the top, we talk about 36 weeks and 38 weeks. Just the lack of comfort lying in a dental chair would be a contraindication, again, unless the dental care is absolutely necessary, which in my way of thinking would be pain or infection. Other than that, we would try to avoid the end of the pregnancy, the latter part of the third trimester. So let's look at local anesthetics, okay? And this is from lidocaine. This is from both the United States and Canadian drug package insert, and you'll be seeing a number of these. This is 2021, and under pregnancy, just highlighting the bottom of that, it says that these drugs should be used with caution, especially during early pregnancy when maximum organogenesis takes place. Again, that's what I was saying. We try to avoid the first trimester of pregnancy because that's when things on their own, when things go wrong with the pregnancy, that seems to be the time it occurs. So let's now look specifically at the use of local anesthetics on the pregnant patient. And the question, of course, is, are they safe? Are local anesthetics safe to administer to a pregnant patient? And what I want to do is I want to look at the classification of safety, not just for local anesthetics, but for all drugs during pregnancy. And in the United States, we have the FDA, the Federal Drug Administration, the Food and Drug Administration, my bad. And they have a pregnancy list category chart, which you see in front of you. So what I want to do then is look at this risk category and how it relates to drug administration. This category, this risk letter category has been in use now since 1979. And you can see, I'm not going to go into each of these. I just want you to see that these are the classifications. We have A, B, C. The next category down goes through each of the 3 trimesters of pregnancy. We have category D and we have X. X, obviously, I don't know if it's obvious, but X would mean we know for a fact that this drug is going to produce problems both in animals and humans, and the risk clearly outweighs the benefit to the mother. Local anesthetics. What are their classifications? So all the local anesthetics we have in dentistry, and that we're including on the bottom of that chart, epinephrine, are either a pregnancy category B or C. So what is B? The definition: animal studies show no risk or adverse fetal effects, but controlled human first trimester studies are not available, and there is no evidence of second or third trimester risk. Category C, you weigh the risk versus the benefit. Animal studies show adverse fetal effects, but no controlled human studies. Again, weigh possible fetal risk versus the maternal benefit. So something happened in 2015. The Food and Drug Administration had been receiving comments from physicians, and I'm assuming some dentists, saying that the letter system was confusing to many physicians and also to many of the patients. So what they did in 2015 was they got rid of the 5-letter system, and they've replaced it on the package insert with narrative sections. And these narrative sections, which increase the size of the package insert, have discussions of pregnancy, of lactation, and the effect of medications on both males and females of reproductive potential. Now, these are not in effect everywhere right now. So any drug that was approved by the FDA since 2015, yes, the category, the narrative is there. Drugs that were approved after 2001 will be phased in gradually, and drugs that have been around before 2001 are not subject to the change, but the category, the A, B, C, D category has to be removed. So one more time, the local anesthetics we have are all categorized as Bs or Cs. Now, keep in mind, remember, research on pregnant patients is virtually impossible, but local anesthetics, the amides, the drugs we're using, have been around since 1948. And it is estimated conservatively that every year, 1.96 billion anesthetic cartridges are administered worldwide in the dental profession, with lidocaine #1 at about 1 billion cartridges and articaine #2 at 600 million cartridges. So think about that. 1948 to now is what, 74 years. Almost 2 billion cartridges are administered in dentistry every year. If there were a problem with local anesthetics administered to a pregnant patient, we would have seen it by now. So really, the evidence, basically, the evidence is showing us, clinical evidence, that there isn't a problem. So in the United Kingdom, this is the drug package insert from lidocaine. And what it says, highlighting in blue, this medicine can be used during pregnancy without risk to the fetus, provided that it is taken as prescribed. Okay, so again, there's no evidence whatsoever that local anesthetics are going to be a problem in a pregnant patient. And just keep in mind that any drug that we give to a patient, whether it's oral or injected, whether it's a local anesthetic or a CNS depressant, will be found in the developing fetus. So let's just, in wrapping up our discussion of local anesthetics, there are no contraindications to the administration of local anesthetics during pregnancy. But dental procedures, routine, non-urgent procedures, might best be postponed until after the birth of the baby. When local anesthetics are used with or without epinephrine, they should be administered in the smallest dose and the lowest concentration of epinephrine. Now, if I have to select a drug for use in a pregnant patient, there is one drug, and that drug is articaine. And as we will discuss later in the program, I prefer articaine in the pregnant patient because of its shorter elimination half-life. Again, I'm not going to discuss it right now. We'll come back to this in just a little while. So let's talk about sedation in the pregnant patient. And again, the question is similar. Are central nervous system depressant drugs safe to administer to a pregnant patient? And think about this. There are pregnant patients, yes, who need local anesthesia. I'm sorry, who are fearful of going to the dentist. So sedation, if necessary, is indicated. I would recommend strongly that prior to sedating this pregnant patient, a consultation with her OBGYN is recommended. Now, sedation, inhalation sedation, nitrous oxide, oxygen, okay, is my preferred technique in the pregnant patient, basically because you administer it, it does its thing. At the end of the procedure, you administer 100% oxygen, and within a matter of minutes, 3 to 5 minutes, it is essentially gone from both the mother and the fetus. Nitrous oxide is considered to be a pregnancy category C here in the United States. Okay, risk versus benefit, and again, weigh the possible risk versus the maternal benefit. Now, oral sedation, which is again popular, and the drugs that we use primarily in dentistry worldwide are the benzodiazepines. I have two here, triazolam on the right, brand name is Halcyon, and on the left we have midazolam. And these drugs for pregnancy are category D. And if it's a D, I would strongly recommend against their use in the pregnant patient. There is positive evidence of human fetal risk. So again, when it comes to sedation, nitrous oxide oxygen is preferred in the pregnant patient. Oral sedation would not be, by the way, benzodiazepines are also used intravenously and such. So I would recommend against that in the pregnant patient. Now, back to the sedation again. In the first trimester, as I said earlier, we try to avoid doing dental treatment, and we're going to try to avoid any sedation in that first trimester. The second and third trimesters, sedation, nitrous oxide, if necessary. So let's now move on to the female who has now given birth and is going to be breastfeeding, the nursing mother. Go back to our statement earlier, any drug, including local anesthetics and sedatives, will be found in the mother's milk. So let's talk first about local anesthesia. And essentially, we're just going to follow through. Local anesthetics were not contraindicated in our patient who is pregnant, and there are no contraindications to the administration of local anesthetics, either with or without a vasoconstrictor, while the mother is nursing. So 2021, United Kingdom, drug package insert for lidocaine. This medicine can be used during breastfeeding without any risk to the fetus or the breastfed child, provided that it is taken as prescribed. In the UK, Articaine from 2020. Breastfeeding can be resumed after 5 hours following anesthesia. So yes, it's okay to use these local anesthetics on a nursing mom. They're safe. However, the mother herself may not want to expose their infant to any unnecessary drugs. And I have seen this many, many times during my 40 years at USC. The drug is safe. However, I do not want to expose my baby to any drug that is not necessary. So the term we have, and the term that is used officially, is pump and discard. The unofficial term is pump and dump. And what that basically means is I think it's obvious, is you pump the milk and you get rid of it. So the Food and Drug Administration in the US recommends pump and discard for 9 hours with lidocaine, bupivacaine, and prilocaine. Yet for Articaine, pump and discard is only for 4 hours. And we'll talk about the reason for that a little bit later, but it has to do again with its shorter elimination half-life. The drug is gone from that person's body a lot faster. Articaine is gone a lot faster than other local anesthetics. Sedation, if necessary, absolutely, if necessary. And by the way, that's true for any patient, whether they are geriatric, pediatric, nursing, pregnant, or anybody, sedation if indicated. And once again, inhalation sedation with nitrous oxide oxygen is preferred for the same exact reason. It will leave the mother a lot faster, within 3 to 5 minutes, with the delivery of 100% oxygen. Oral sedation is indicated, yes. And we talk about, again, the benzodiazepines are good medications here. But again, they hang around. They hang around in that patient's blood a lot longer and will be found in the milk. So again, from my preference strongly is inhalation sedation with nitrous oxide oxygen. So I use the term pump and discard, pump and dump. So, and the question then is, how important is it? Well, here's a group that deals with drugs every day, the American Society of Anesthesiologists. And in 2019, they came out with a statement on resuming breastfeeding after anesthesia. And very, very simply, I'll read this to you. Patients should resume breastfeeding as soon as possible after surgery because anesthetic drugs appear in such low blood levels in breast milk. It is not recommended that patients pump and dump. So how important is pump and discard? It isn't, except for the nursing mother. You always have to keep that in mind. If you're going to use a drug, whether it's a local anesthetic or a sedative, and the mom is concerned about this, go with the pump and discard. And when it comes to local anesthetics, if it's lidocaine, mepivacaine, prilocaine, or bupivacaine, they pump and discard for 9 hours. And if the drug is articaine, they can pump and discard the milk for 4 hours. So let's take a look at geriatrics. I had to throw that picture in on the left. In case you don't know it, this is me, Dr. Malamed. Geriatrics, depending upon, there are different categories of being old. From 65 to 74, I'll use the middle category. You are the young old. From 75 to 84, you are old. And from 85 and above, you are the old. So what are major concerns during our treatment of the geriatric patient? And it has to do with overreacting, hyper-responding to drugs. And if there is liver dysfunction, hepatic dysfunction, a drug may not be eliminated as rapidly from the bloodstream as it would be in a patient with a normal liver function. So let's take a look at the normal distribution curve, what's called the bell-shaped curve. And what that, let me go back to that, the dark blue area would be a normal responding patient. 70% of people in the dark blue, given a drug, will respond appropriately to it. 15% of our patients on a given dose of a drug, well, they need more. They're hypo-responders. But the other 15% of patients are hyper-responders. And what we're dealing with here now is as people get older, and as a rule, it's patients who are over 65, and that's an arbitrary number. But the percentage of hyper-responding patients to the usual dose of a drug will increase. So again, if you're treating a geriatric population, for example, a patient who did well, I'll talk about an old sedative drug called Valium, diazepam, where 5 milligrams is the average dose. In a geriatric population, 5 milligrams might be too much for that patient. The patient will become over sedated. So we are going to see an increase in the percentage of patients who hyper-respond to the, in quotes, usual dose of the medication. Locals are indicated. For the reason I'll discuss later, articaine again is preferred. And as I said a number of times, the dosage, and this is true for all dental patients, but the injected dose should be kept as low as possible. As long as you can achieve profound anesthesia, use the smallest dose that is needed. Block injections, the inferior alveolar nerve block, the Gauge mandibular block, the anterior superior alveolar nerve block, posterior superior alveolar nerve block, where with one injection, you're getting anesthesia of 3, 5, 7 in the mandible, all 8 teeth, much preferred to infiltration. Infiltration, you're only getting 1 or 2 teeth. With a mandibular block, you're getting all the teeth. So you want to keep your dosages as low as possible, and block injections help you do that. Epinephrine should be administered, but keep in mind that the older patient tends to overreact. And using epinephrine in the UK in 1 in 80,000, the United States and Canada 1 in 100,000. There's no problem with it, but again, older patients might over-respond. And what does that mean? Tachycardia, in quotes, what is called an epinephrine reaction, unquote. the face gets red, they begin to shake, they have a tachycardia. And in an older patient who may have underlying cardiovascular problems, this could be a problem. So again, we want to use the lowest concentration of epinephrine that's available. And for most countries, that is epinephrine 1 in 200,000. And we want to use the smallest volume that's appropriate for effective pain control. Also keep in mind that there are dental procedures where plain locals, drugs which do not contain epinephrine, can be used. And if that's, if it's possible, then use that plain local anesthetic. Like every other patient population, sedation is indicated in the fearful geriatric patient. And the reason is, again, we want to minimize endogenous catecholamine release. And what that means really is patients who are scared release epinephrine and norepinephrine, which stimulate the cardiovascular system, elevate the blood pressure, increase the workload of the heart. And in an older patient who has underlying heart disease, this could be dangerous. So sedation is indicated, and to say it again, inhalation sedation, relative analgesia with nitrous oxide oxygen is the preferred technique. And for any number of reasons. Number one, it's a sedative. It's an excellent sedative. But unlike most other sedatives, nitrous oxide also raises the pain threshold. And you're giving a patient oxygen. And oxygen is good. Now, the other thing is, number four, in the presence of liver dysfunction, where oral medications cannot be metabolized as rapidly as normal, nitrous oxide does not undergo metabolism in the body. So it can be used effectively and safely in patients who are older and have kidney or hepatic dysfunction. Oral sedation, yeah, it can be used, but if you're going to be using a medication, I'm showing you here triazolam, Halcyon, the dose should be on the low side of average for adults, keeping in mind that there's an increased percentage of patients who hyperrespond. So for example, this patient at the age of 20 may have 0.25 milligrams of triazolam, was a very effective dose. At the age of 70, that same dose may wind up being too much. They'll be overly sedated. Keep the dose low. All right, so let's move on now to pediatrics and talk about local anesthesia. So what is our major concern during our treatment of the pediatric dental patient? And it's a serious concern. It's elevated blood levels of the local anesthetic drug. And most of the adverse reactions that occur to local anesthetics in our profession occur in patients who are lighter weight, under 30 kilos, to translate that, 66 pounds. And what is that major drug-related complication? And it is very simply local anesthetic overdose. Local anesthetic overdose has a new name. If you look at the literature, it is now being called LAST, L-A-S-T, local anesthetic systemic toxicity. So what is an overdose? Well, an overdose of any drug, be it alcohol, a narcotic, local anesthetic, an overdose occurs when the blood level of that drug in what is called its target organ is too high. Now, what is a target organ? A target organ for a drug is the place in the body where the drug exerts a clinical action. And for local anesthetics, obviously nerves. Local anesthetics depress the functioning of nerves. But along with that, local anesthetics also target organs are the heart muscle, the myocardium, and the brain. The brain is much more sensitive to blood levels of local anesthetic than the myocardium. And for that reason, again, what local anesthetics do, and the only thing that they can do, is they depress. They depress the functioning of nerves. That's how they produce anesthesia in the mouth. They also depress the functioning of their target organ. So this slide is showing you the usual progression of signs and symptoms of local anesthetic overdose following the administration of an overly large dose administered correctly. And if you go to the left in blue, the initial signs and symptoms are central nervous system. And what happens, it leads to seizures. The typical overdose of a local anesthetic is a tonic-clonic seizure. It is rare, in my experience going back to 1973, to see a local anesthetic overdose that goes beyond that and starts affecting the myocardium. But again, seizures leading to respiratory depression, and eventually, if the blood level gets extremely high, to cardiac arrest. In a textbook published in the 1970s by a famous medical anesthesiologist, Rudolf de Jong, he made this comment on convulsant blood levels. The brain responds to the concentration of local anesthetic delivered to it by the bloodstream and cares not at all how the drug got into the blood. So the two most common etiologies of local anesthetic overdose are direct intravascular injection or the administration of an overly large dose of that medication. Intravascular injection, one cartridge of any local anesthetic, articaine, bupivacaine, lidocaine, bupivacaine, prilocaine, one cartridge of local anesthetic administered rapidly intravenously will, without any doubt, produce the rapid onset of a very severe overdose reaction. Luckily, we can prevent it. The administration of an overdose can be prevented simply by aspirating. I mean, this is part of your basic local anesthesia technique. You aspirate before you deposit the drug. And essentially 100% of the time, we can prevent this from occurring. However, and again, my experience with this has gone back now more than almost 50 years. Overdose is most likely to occur in a lighter weight patient who receives too much of a plain local anesthetic. Now, I don't have the time right now to go over this in detail, but if you're treating a child who is lighter weight, up to 30 kilos, and you're treating one quadrant, then a plain local anesthetic is fine. Whether it's bupivacaine, prilocaine, or lidocaine, a plain local anesthetic would be fine. But in that lighter weight patient, if your treatment plan exceeds one quadrant, if you're going to go to 2 quadrants or more, always use a local anesthetic, which contains a vasoconstrictor. And as I said a number of times before, articaine with epinephrine is my preferred local anesthetic. Keep in mind also that the volume of local anesthetic required to anesthetize a child is lower. You don't need as much volume. In fact, most of the overdose reactions that occur in dentistry occur in a younger child who is well behaved, being treated by a younger general dentist. And the reason, sadly, is because we as general dentists tend to administer larger volumes of local because we're dealing with adults. And we don't think that when this little kid who weighs 25 kilos, 55 pounds is in the chair, we administer adult doses of medications to that child. So it behooves you, especially if you are a non-pediatric dentist, to be able to determine the maximum recommended dose of a local anesthetic to the patient you're treating. So number one, you need to know the weight of that child. Now, the maximum recommended dose is an estimate of the upper limit of drug dose beyond which the drug's efficacy is not increased, but side effects begin to outweigh the beneficial effects. So the maximum recommended dose of a drug is where risk begins to outweigh the benefit. This is a chart I put together of the 5 local anesthetics, and going back to the 3 countries, we have Canada, the United Kingdom, and the United States, the maximum recommended doses in each of these countries. Now, it's interesting because 3 of the drugs, articaine, lidocaine, bupivacaine, which are the 3 most used local anesthetics in our profession, there's similarity. All 3 of these countries have the same milligram per kilo with absolute maximums of these medications. 2 drugs, prilocaine and bupivacaine, there are considerable differences. Again, bupivacaine is used primarily for post-surgical pain control, and prilocaine, depending upon where you are, in the United States is not a major factor, but in some countries it is. So again, what you need to do, regardless of where you practice dentistry, if you pick up the package insert for the drug that you're using, and on that package insert, there will be an indication of the maximum recommended dose of that drug. And another problem question, if you will, is do we teach this consistently? And this is a survey that was done of there were 55 dental schools in the United States, published in 2018. And what they found is that there was a considerable variance between the package insert and what is being taught in dental schools. 84% of the respondents in this survey said that the pediatric dentistry department presented its own material on safe maximum doses. In other words, I teach local anesthesia, and I'm giving you the numbers I just showed you. And it turns out that our pediatric dentistry department is teaching different numbers. So for a dentist out there, especially the younger dentist, this becomes very, very confusing. Simply, you keep the dose as low as you possibly can. And keep in mind that children need less medication. So let's talk about sedation in children. And sedation for the same reasons. Why is nitrous oxide such a popular technique? Well, number one, it relaxes the patient, it provides soft tissue anesthesia, and it elevates the patient's pain threshold. Oral sedation is fine. There's no contraindication. And again, midazolam is available as a syrup, which makes it more usable in young children who would be a little reluctant, perhaps, to swallow a pill. But there's no contraindication either to nitrous oxide. In fact, it is the most popular sedation technique amongst pediatric dentists. More than 90% of pediatric dentists here in the United States employ nitrous oxide, and many of them combine the nitrous oxide along with oral sedation. So let me just talk about why I like Articaine. I've said it on a number of occasions that Articaine is my preferred local anesthetic. I've also mentioned that I like inhalation sedation. So let me explain this just a little bit to you. Starting out with inhalation sedation. As I mentioned a little while ago, this is 3 surveys published by the Academy of General Dentistry, the American Dental Association, and a survey of 716 patients published in 2011. Inhalation sedation is used in over 70% of dental offices. And if you go down, the combination of inhalation sedation plus oral sedation is also very popular. So it is a very, very popular and very, very safe technique. For the reasons I already mentioned, keeping in mind that it's a great sedative, it also helps you with pain control, and you get soft tissue analgesia. And oxygen, of course, is good. So there's really no downside to this in our pediatric patients, in our geriatric patients, nursing mothers, and in the pregnant patient. But let me spend some time discussing Articaine, because Articaine, the newest local anesthetic, and in my opinion, is the most effective and the safest of all local anesthetics. Articaine was synthesized in 1969, introduced into dentistry in 1976. Articaine represents the only local anesthetic that has been designed for dentistry. And as of 2019, Articaine was the second most used local anesthetic in dentistry worldwide, with about 600 million cartridges being employed annually. Canada got the drug in 1983, the United Kingdom in 1998, and here in the United States, we got the drug in the year 2000. It is classified as an amide local anesthetic, along with the other amides, prilocaine, bupivacaine, lidocaine, and bupivacaine. However, Articaine possesses some of the good properties of the ester type local anesthetics. And there are a number of them. I don't have the time to go into them all, but I want to discuss this one because this is the one to me that makes this drug the safest, and it is metabolism. Most drugs, not just locals, undergo metabolism, also known as biotransformation, also known as detoxification in the liver. But the ester type local anesthetics, the procaine, novocaine, tetracaine drugs, they are metabolized in the cardiovascular system, in the blood. As soon as they leave that nerve, enter into capillaries, the process of metabolism starts. So let me just bring up this statement here. It's called the elimination half-life, which I mentioned casually a little while ago. The elimination half-life for a drug is the time required for the blood level of that medication to decrease by 50%. And if you look at the chart on the right, at 1 half-life, blood levels decrease by 50%. At 2 half-lives, it's gone down by 75%. We normally say that a drug is eliminated from your system, the cardiovascular system, at 6 half-lives, when in fact its blood level is decreased by 98.56%. So look at the esters. Procaine, Novocaine. Half-life is 6 minutes, gone in 36 minutes. Now keep in mind, this has nothing to do with the duration of action of the drug. The duration of anesthesia is as long as the drug stays in the nerve. This begins once the drug leaves the nerve. So the esters as a group undergo metabolism, elimination from the blood a lot more rapidly. However, the amide local anesthetics undergo metabolism like most drugs in the liver. The liver only receives 6% of the blood that is being pumped out of the heart with every contraction. CO is cardiac output. Only 6% of the blood goes to the liver. And what does that mean? Look at the half-life. Half-life of lidocaine, prilocaine, 90 minutes. 6 times the half-life, 540 minutes. By the way, our FDA said that with nursing moms, you pump and discard lidocaine, bupivacaine, prilocaine for 9 hours. 540 minutes is 9 hours. Articaine, 90 to 95% of articaine is metabolized in the blood, just like the ester local anesthetics. We classify it as an amide, but this one property, it is metabolized in the blood like the esters. And this is a study done by Wolfgang Jakob, where he took 120 milligrams of lidocaine, 120 milligrams of articaine, and over an hour and a half measured the blood levels. And you can see a significant, more rapid drop in the blood level of articaine compared to lidocaine. So what is the half-life? What is the elimination half-life of articaine? Well, in adults, it's 20 to 27 minutes. In pediatrics, 18.5 to 23.5 minutes. And in geriatric population, about 27 minutes. So here's a chart starting on top in gray with the ester type anesthetics, on the bottom black, the amides, and in red, articaine. So again, the half-life of articaine is significantly more rapid, which is the reason I believe that articaine is the preferred local anesthetic if you're pregnant, if you're nursing, in younger children, and in geriatric patients. So allow me to summarize. We talked about 4 classes of, in quotes, special patients, unquote. The pregnant patient, the nursing mother, the older patient, and the younger patient. And we looked at the use of local anesthetics and central nervous system depressants in these groups of patients. So when it came to the pregnant patient, the 2 things we're concerned about is the effect of our medications on the pregnancy. And first trimester, we try to avoid doing any dentistry. Second and third trimesters, we can. At the end of the pregnancy, toward the end of the 3rd trimester, we try to avoid doing dentistry because of the discomfort of this near-term female lying in a chair. But the local anesthetics, again, during pregnancy, even though the research is sparse, the amides have been around since 1948. And quite honestly, if there were a problem with local anesthetics in pregnancy, we would definitely know about it by now. Nursing. Any drug, including our local anesthetics and sedatives, are found in the mother's milk. But the evidence has shown that there's no problem. There is no problem. Keeping in mind that the mother may not want to expose her baby, her infant, to any medication, which brings back the concept of pump and discard. So if you're using lidocaine, mepivacaine, prilocaine, or bupivacaine, pump and discard for 9 hours. If you're using articaine, pump and discard for 4 hours. Geriatrics, keep your doses low. All right, you know, full cartridges are not needed for every injection we give in the patient's mouth. When you're using epinephrine, adrenaline, use a 1 in 200,000 concentration if you have it available. Okay, older patients tend to hyper respond to drugs, and the catecholamines, epinephrine, are one category of drug where we don't want to stimulate that patient's heart. Again, in the presence of any underlying heart disease, this could be potentially dangerous. So just keep your doses low, use the lowest effective concentration of your vasoconstrictor, and there should not be a problem in this patient. And in pediatrics, this is where the problem comes in. As safe as our local anesthetics are, and they are, I normally start my programs by saying that these are the safest drugs in medicine for the prevention and management of pain, with an asterisk that says when used properly. Okay, so know your patient's weight. Most of these problems occur in patients who are under the weight of 30 kilos, 66 pounds, and go back to that chart, figure out the maximum recommended dose. You don't have to go to that maximum dose. You want to keep your dosage as low as possible. And again, with young children, you don't need a lot of local anesthetic per injection to achieve good pain control. So with that, I want to thank you for joining me in this webinar. I really hope that has been of some benefit to you. This is my email address again. It's my last name, Malamed, at usc.edu. Thank you all very, very much. Okay.
So
We're back.
welcome back. Yes, we're back. So thank you.
Before you start,
Yep.
the next time we do a webinar, I am going to sell advertising space on my forehead. I think everybody who watched this webinar knows Malamed's forehead better than they do his beard. So I have to learn how to look at the camera from now on.
No, but
It was
yes.
interesting.
Yeah, it was a nice shot. Thank you very much for this lecture, Professor Malamed. Thank you everyone for commenting. We've had a lot of questions, I have to say, so I have to choose. But here it comes. First question I've had is about articaine, which is your drug of choice. It's recommended only as from 4 years old. What's actually your point of view on this?
Well, I can tell you exactly why it's 4 years of age and above. And when I was at USC, this is now going back to 1997, 98, when Septidont, the people sponsoring this program, wanted to get articaine approved for sale in the United States. USC Dental School, along with 29 other dental schools in the United States and United Kingdom, were involved in the study. And a total of 1,332 patients were treated. Conservative dental treatment was done. And 888 got articaine, 444 got lidocaine. Okay. We enrolled patients in the studies from the age of 4 and up. So the studies proved to the FDA that articaine is safe and effective in patients who are 4 years of age and above. Very simple. That's why it says I think in almost every country in the world, that package insert is going to say 4 years of age and above. Now, the question, which I think maybe wasn't asked, but it's implied. Can Articaine be used in patients who are under 4 years of age? And I have to say unequivocally, absolutely yes. And there is a growing body of literature in pediatrics showing the safety of Articaine in younger patients who are under the age of 4. Now, if anybody in the audience, again, wants information, I'll send you the articles. Just email me. Email me and ask for the articles on using Articaine in pediatric patients. I will send you a lot of them. But the answer is absolutely yes. Articaine is safe and effective in patients who are under 4 years of age.
Thank you. Your point of view is quite clear on this. I've actually received a lot of questions also on things that you haven't mentioned during the webinar. So this is a nice way to go a little bit further. First of all, what is your sense on topical anesthetics and how can they be combined? Is there a maximum dosage that you have to think about when using a topical and injectable?
Okay, well, topicals work. I mean, one of the things that everybody who's listening to this program, I think right now we have 750 people who are still awake, most of them. Topicals work. And, the whole goal is we do not want to hurt our patients. Patients go to the dentist, and sadly, many of them equate dental treatment with pain. Local anesthetics, as I said in the program, are the safest and the most effective drugs we have for pain control. The problem is we have to inject them. It's that needle. Okay, topicals, if you take a little bit of topical anesthetic on a cotton applicator stick, just a little bit, put it in the buccal fold, just at the point where the needle is going to be placed, leave it there for 1 minute. Okay, you can penetrate that soft tissue painlessly anywhere in the mouth. Now, the difficult problem is the palate. And again, we didn't discuss this on the program, so let me throw this out because this is something that is relatively new, and it's something that if you have a pen in front of you, write this down. Patients don't like getting palatal injections because they hurt. Dentists don't like giving palatal injections because their patients don't want to be hurt. And the reason it hurts is that the tissue on the palate is dense, it is firmly adherent to bone, and when you're giving that palatal injection, your hand is shaking because you have to push it so hard. What if you didn't have to give palatal injections anymore, but still got palatal soft tissue anesthesia? So again, I can't get into the articles right now, but this is the one study of many that was done. Extraction of a permanent maxillary tooth. So they divided into 3 areas: anterior teeth, premolars, and molars. And what they did was they administered either lidocaine by buccal infiltration or Articaine by buccal infiltration. And they started out with 1/3 of a cartridge, which in the United States is 1.8 ml. So they gave 0.6 mLs buccal infiltration. They waited 2 minutes. They tested for palatal soft tissue anesthesia. If they didn't have palatal anesthesia in 2 minutes, they gave another 0.6 and waited 2 more minutes. So now we have 4 minutes, 1.2 mLs of buccal infiltration of Articaine or lidocaine. If they didn't have soft tissue anesthesia on the palate at that point in time, they gave the remaining 0.6. So now at the end of 6 minutes, patients had received a full cartridge, 1.8 mLs of local anesthetic, Articaine or lidocaine. 1.3% of the lidocaine patients had palatal soft tissue anesthesia. 83% of the Articaine patients had palatal anesthesia adequate enough to have an extraction done of a permanent tooth comfortably. And that was only 6 minutes. Okay, I'm thinking most dentists wait longer than 6 minutes. They give an injection, they wait probably around 10 minutes. So if we have an 83% palatal soft tissue effect after 6 minutes, with a full cartridge of Articaine in the buccal fold. If you were to wait 10 minutes, that 83% is going to go up. So again, this wasn't part of the program. However, it's a great question. Topicals work, yes, they work everywhere in the mouth, but they don't work that well in the palate because of the nature of the soft tissue. Use Articaine. If you want palatal soft tissue anesthesia, give a full cartridge in the buccal fold by the tooth you're going to be treating, whether it's extraction or restoration, doesn't matter. If you need soft tissue anesthesia on the palate, full cartridge, wait at least 6 minutes, test the palate. After 6 minutes, if it's not anesthetized enough, wait another 2 minutes. But here's the thing, even in those patients who didn't have profound palatal anesthesia, they had some. Now, what does that mean? If they had to get a palatal infiltration, they didn't feel it because they had some small degree of anesthesia. So back to that question, topicals work a little bit, buccal fold, leave it for 1 minute, you can penetrate soft tissue painlessly. Okay?
Great. Thank you very much. I've had a few questions, as I said earlier, about something you didn't talk about. What about mixing? That's it. That's the term I've read, but it's actually buffering. Sure. What do you think about buffering for those patients?
Oh my God. Okay. I have been an advocate of buffering now going back about 15 years. And if anybody ever hears me speak a full day on local anesthesia, the two things I finish at the end of the day, and I'm saying this is your takeaway. Number one is that use of Articaine by buccal infiltration in the maxilla for palatal soft tissue, and also the use of Articaine in the adult mandible by a mandibular molar to achieve profound pulpal anesthesia. And the other thing I've been really pushing a lot is use of buffering. Now, long story short, again, I will be glad to send anybody who emails me a lot of material on buffering. The pH of a local anesthetic, which contains epinephrine, adrenaline, is about 3.5. It is highly acidic. And it burns. When you put that first couple of drops of local anesthetic in with a low pH, the patient feels a burning sensation. A lower pH local anesthetic works more slowly. The onset of anesthesia is slower than that same drug if it was, in quotes, plain. Plain drugs have a pH of around, mepivacaine plain, 3% plain. pH is around 6.5. It works faster. It's also more comfortable. What buffering is the addition of a small amount of sodium bicarbonate to the cartridge to raise the pH to around 7.35, 7.4. And the studies have shown, and it's been around now since about 2009, 2010, the doctors who use buffering love it. Number one, it works very, very rapidly. Let me just go through these. It works rapidly, more profound anesthesia. It's more comfortable for the patient. Now, onset of anesthesia. So in the study that we did, patients, we gave them inferior alveolar nerve blocks, in quotes, mandibular blocks or IDBs, depending upon where you're practicing. And we used lidocaine because lidocaine is still the #1 drug used worldwide in our profession. And the onset of anesthesia with the unbuffered traditional lidocaine was 6 minutes and 35 seconds, more or less. The same patients, when they got the Articaine, I'm sorry, not Articaine, when they got the buffered lidocaine, it was 1 minute and 51 seconds. Think about that. 6 minutes onset for pulpal anesthesia, 1 minute and 51 seconds onset for pulpal anesthesia in the mandible with buffered lidocaine. And another thing about I mentioned it's also more potent. The Journal of the American Dental Association, March of 2019, the cover article, and I wasn't involved in this study, was the use of buffered local anesthetics on pulpally involved teeth. And if anybody in this audience is an endodontist or is a dentist who treats infected teeth, mandibular molars are tough. They are the hardest teeth in the mouth to anesthetize. And what they found in this study was that buffered anesthetics have a much greater likelihood of achieving profound pulpal anesthesia on infected teeth. So buffering is something I've been advocating, buffering and the use of articaine. In fact, buffered articaine, okay, it's a great combination right there. So buffering, look into it. Sadly, at this point in time, the 28th of June, 2022, systems for buffering local anesthetics are not available outside the United States. You can buffer, absolutely. You can buy a bottle of sodium bicarbonate at a pharmacy. And before you do that, I would recommend contacting me because you want to do it right. There's nothing serious that can go wrong, but contact me, okay? But in the United States, if anybody here is in the United States, I'm sure there may be a couple of you, and I'm going to use a brand name if you don't mind. There is one system for buffering that is really good, and it's called Onset, as in onset of anesthesia. So if you're in the United States and you're interested in buffering, again, either contact me or look into that one product. But buffering it'll be out there everywhere in the world, and when it is, give it a serious consideration.
And when it is everywhere, we'll think about your wise words. Again. I've had a lot of questions regarding sedation, and a lot of questions regarding the maximum length of use of nitrous oxide. I mean, how long can you use it for on those special patients, pregnant or pediatric patients?
Okay, so the average, let's talk about nitrous oxide specifically. Let's talk about sedation in general. I teach sedation. I teach nitrous, I teach intravenous sedation. And one of the things we talk about is length of appointment. For how long should a patient be sedated? Because we have experience with doctors who sedate patients for 6 and 8 hours at a time, which I personally believe is, can I say the word crazy? It makes no sense. We recommend strongly 2 hours maximum when it comes to sedation, whether it's intravenous, oral sedation, or nitrous oxide. With nitrous, there's not really a significant problem if you go beyond that. Okay, when it comes to oral sedation, first of all, you'd have to repeat your drug dosages, and you don't want to do that. But when it comes to intravenous sedation, again, you're giving larger and larger doses of medication. But one of the things, and there have been many studies done in anesthesiology, after about 2 hours, patient's physiology begins to deteriorate. Now, it doesn't mean if you're a healthy patient to start with, it doesn't mean anything disastrous is going to happen. But the longer you have that patient sedated and you are treating them, things can go wrong more easily. So we recommend not more than 2 hours. Again, is it a hard and fast thing? The answer is no, it's not hard and fast, but 2 hours. Think about another thing. The doctor's ability to treat that patient begins to deteriorate after a certain amount of time. When I used to work in the operating room, and if a surgical case went for many hours, and some cases went for many hours, the physician, the surgeon, they would swap out, they would change. The anesthesiology team would change, because concentrating and doing a good job, if you will, as time goes on, it deteriorates. So let me just finish up and say 2 hours should be a max. Okay.
All right, thank you. And to follow up on that, there's also a question about the ratio of nitrous oxide to oxygen that should be used. That's recommended.
Okay.
First of all,
that's
globally, that's an easy one.
Well, I mean, the first part of that is simple, because the answer is I don't know. I showed you that slide of a bell-shaped curve, and I said that The average patient, that dark blue area, is what most patients respond. So the word that is so important, and why nitrous oxide is such a great technique, is that you can individualize the dose for every patient. The word is we titrate. So if going back 30,000 patients, let's say, going back to 1973 at the University of Southern California, I made up that number, it's not 30,000, it's less than that. But if we titrate nitrous to the clinical effect, now we want that patient to be relaxed. So we can do it. You know, this is a patient who is combative, a patient who just doesn't want to be in that dental chair. So we sedate them to a point where they don't care. They just lie there. The average patient, when you titrate the nitrous in, will require anywhere between 30 and 50% nitrous oxide. That would be that dark blue area in that bell-shaped curve, the average patient. However, there are some patients who need more than 50% nitrous. They need 60 or 70. Nitrous oxide machines worldwide have built-in fail-safes where you cannot deliver more than 70% nitrous, which means you can't give them less than 30% oxygen. And some patients need more than 50%. But on the other hand, there are about 15% of the population where even 30% would be too much. And so if you titrate the nitrous in and your patient is at 20% nitrous oxide, for example, they're fine. Why give them more? So the answer to that question is there is no dose for everybody. You will individualize the dose by titrating your nitrous oxide. I can't hear you.
Sorry, I had muted myself. I'm sorry. There are a lot of questions which come pouring in. I can't actually ask you all of them because we'd be here for another 4 or 5 hours. There's one of them which comes back a lot. It's about the best way to anesthetize an infected tooth from your point of view.
Well, one of the programs I give is called The Dilemma of a Hot Mandibular Molar. In fact, I just gave this at an endodontic meeting in Michigan last week. Last year at the International Endodontic Meeting in Chennai, India, which unfortunately was done on Zoom, I gave the same lecture. It is, you know, endodontists have the hardest challenge in dentistry, and that's, again, the infected mandibular molar. And okay, there is no answer. There is no guaranteed way of doing it, which is a lie. There is a guaranteed way of doing it, and it's called general anesthesia, which is not a logical thing. For most of the audience out there, the availability of general anesthesia, it doesn't exist. Okay, so let's take that away. When it comes to local anesthesia, there is no guarantee whatsoever. So putting two things together that I talked about, the use of articaine and, if available, buffering. So here's what I would recommend. Again, we're talking specifically now about that infected mandibular molar. Okay, we're going to do an inferior alveolar nerve block, IDB. You're going to use articaine. If buffering is available, you're going to use it. But you're going to use articaine for the IDB. Then, as soon as you finish giving your inferior alveolar nerve block, you're going to take another cartridge of articaine and give a buccal infiltration in the mandible adjacent to the mandibular molar. You're going to do the endo on. Okay, and that combination of a lidocaine IDB, inferior alveolar nerve block, plus the articaine buccal infiltration, it's not a guarantee you're going to get into that pulp chamber painlessly, but it's the best we have right now. It works. You know, I have met, changing that subject away from the infected tooth, but I have met many doctors, many 20 or 30 over the last couple of years. Well, I've met nobody over the last couple of years because I've been sitting at my computer, but you know, at meetings, and meetings are now opening up, who have told me Dr. Malamed, I have not given a mandibular block in the last 3 or 4 years. I started using articaine by buccal infiltration in the mandible, and it works. Now, again, we're talking about non-infected teeth. With the infected teeth, regardless of what drug you use for your block, your mandibular block, your Gaugate's mandibular block, whether it's articaine or lidocaine, always without any exception, give an articaine buccal infiltration of about 1/3 to 1/2 of a cartridge in the buccal fold adjacent to the mandibular molar, and you're going to see a dramatic increase in your success. It'll be an increase in success in non-pulpally involved teeth, and when it is an infected mandibular molar, it'll still be better, but no guarantees of absolute success there.
Thank you. Thank you very much. We know that you're a huge advocate of articaine, but I've had a few times the same question. Is there any case when articaine is contraindicated?
Okay, that's a great question. And my answer is this. Articaine would be contraindicated for administration in a patient where any local anesthetic would be contraindicated. In other words, there's nothing specific about articaine that makes it different from lidocaine and bupivacaine. But there are patients, and these are patients we classify, we call this the American Society of Anesthesiologists Physical Status Classification System. And most of the doctors would understand the ASA system, where an ASA1, we're talking about reviewing the medical history, recording vital signs on a patient, blood pressure, heart rate. And if a patient is a perfectly healthy patient, they're an ASA1. And if I can relate this to traffic lights, an ASA1 would be a green light, go for it. A patient who's an ASA2 and ASA3 are patients who have mild and a little bit more severe systemic disease, asthmatics, patients with epilepsy, patient with diabetes. This would be an amber, a yellow traffic light. And what does that mean? It means proceed with caution. All right, so ASA 1, 2, and 3, treatable, no concern. I mean, they were not concerned, but no real problem. It's the ASA4 patient, and that's the red light, the red traffic light. And sadly, I've been to countries where a red traffic light, which normally should mean stop, in some countries, a red traffic light is merely a suggestion, but that's a different story entirely. Those are the patients who shouldn't be in that chair. These are patients, for example, a patient who had a myocardial infarction, let's use the late term, a heart attack within the last 3-4 months. Somebody with uncontrolled epilepsy, somebody who walks into your dental office, they're asthmatic, and they walk into your office and they're wheezing at that point in time. These patients shouldn't be treated right then. And that means that local, no. That means any local. So again, back to the point you just made. If a patient is treatable, ASA 1, 2, or 3, then local anesthetics are indicated, and articaine is a local anesthetic just like the other one. So there's nothing specific about articaine that would be a contraindication where other local anesthetics would be usable. Took a while to get there, but that's the answer.
It's very clear, very justified. And there's another question on that same topic, is there any time when you recommend using 2 different drugs, one injection after another?
Yeah, and there is. And you know, I mentioned specifically that buffering is only available in one country right now, the United States. This is what a lot of doctors, even in the States, did and probably still do. And I'm sure there are doctors from other countries here who do the same thing. So I mentioned the fact that pH of a local anesthetic, which contains epinephrine, is very acidic, 3.5. And a plain drug has a pH of around 6.5, which makes it more comfortable. So what a lot of doctors do and especially with the mandibular block injection, they take a 3% bupivacaine, no epinephrine, higher pH, and they go in on the IDB injection, and they give maybe a third to a half of the cartridge. And what they're doing is they're getting the soft tissue around the inferior alveolar nerve anesthetized comfortably. The patient doesn't feel burning. But they don't put enough anesthetic in to fully block the nerve, just to make the tissue numb. They take out the syringe, they put in a cartridge of, I'll use the word, the real drug, the drug which contains epinephrine, be it lidocaine or articaine, whichever, okay? Lower pH, and they go in and now they do the real mandibular block injection. But since the patient is already numb from the previous injection of 3% bupivacaine, they won't feel the burning associated with the drug which contains epinephrine. There's nothing wrong with that whatsoever. See, again, in the absence of buffering right now, that's a good way to go. Once buffering becomes available, it doesn't matter, because you can buffer any local anesthetic. And if the pH of a local anesthetic is 7.35, they're not going to feel the injection whatsoever. By the way, here's an obvious question that somebody, if they didn't ask it, they're going to ask. Why doesn't Septidon manufacture buffered cartridges? All right, let's pick on Septidon. You're the world's leading manufacturer of local anesthetics. And the answer is, it'll happen. Believe me, it'll happen somewhere down the line. I don't know if I'll still be around when this happens, but it's going to happen. But here's the thing. When the pH of a cartridge is higher, 7.4, it becomes less stable. The shelf life of the drug, which starts out at 24 months, a cartridge which contains epinephrine is a 24-month shelf life from the time of manufacture. The shelf life will be dramatically less. And it's not, and the other thing is, in most countries, to make any change in the content of a cartridge, in the United States, we would have to go back to the FDA and do a lot of research to prove that it's safe. And let's be honest about this, a lot of research means a lot of money. Okay, and that's why it hasn't been done at this point in time. Will it be done? I guarantee you it will be, because buffering is the future. It is the future. All right.
Well received, Professor Malamed. Well received. Thank you very much. I mean, I'm getting questions basically every 20 seconds, so I don't think we can cover them all today, but I really thank you very much, everyone, for joining today. Thank you very much, Professor Malamed, for being with you. I hope this webinar has been enjoyable for everyone, interesting for everyone. Thank you so much for answering the questions, the big questions I could regroup in some themes. Stay tuned for further sessions that we have, either with you or with other panelists on other topics, obviously. It's always a pleasure working with you. Thank you very much. Do you want to say one last thing before we get off the air?
Same here. No, I've enjoyed doing it. I've done a number of webinars with Septidon, and it's always been fun. And I am still learning. Again, I have a lot of space up here. So I'm going to go to the highest bidder and put some kind of a advertising here for the next meeting I do. No, thank you all very much. And again, if you have any questions or want any more information, feel free to contact me. One more time, my email address is my last name, Malamed @usc.edu. Thank you all very much.
Thank you very much. Just so you know, for the ones who are still here, and you're a lot still, thank you very much for staying until the end. There will be a short survey when you close the window, when we close this webinar, so please answer it. It will help us improve the next sessions, obviously. Thank you so much for attending. Have a good day, have a good afternoon, have a good evening. Thank you so much for joining. Have a good night, even, I think. And thank you so much for joining this webinar today. Bye-bye.
Bye-bye.